Hello, everyone. My name is Jim Douketis, and it's my pleasure to welcome you to this Thrombosis Canada webinar dealing with knowledge gaps in thrombosis. And this is the third of our series of virtual roundtables. The format, just as you have surmised, is that it's very informal and open-ended. We had solicited some questions and clinical cases from the audience, and we've gotten quite a few of them actually. But we also want you to feel like you're part of a real roundtable where you can interrupt us, ask questions in the chat line, and my co-host, Dr. Vicky Tagalakis, and I will do our best to try to address your questions. So we can get started. This is a program that was developed by a multidisciplinary committee. And for tonight's panel, there's a group of us. But first of all, these are the disclosures for the entire panel that helped develop these three educational programs. And tonight we have three other panelists. Myself, I'm a general internist and thrombosis physician in Hamilton, Canada. We also have Dr. Vicky Tagalakis, who's also a general internist and thrombosis physician at the Jewish General Hospital in Montreal. And it's our pleasure to be joined by Dr. Easaw, a medical oncologist in Edmonton, Alberta, and by Maria Marchese, a clinical pharmacist from Sunnybrook Health Sciences Center in Toronto. So welcome to the panel. And in terms of disclosures, you can see these here, and you'll also see that we have taken steps to mitigate potential bias within this educational program. I'll give you a moment to review this. And I'll also mention that this is a program that is accredited through McGill University for up to 1.5 Section 1 credits through the Royal College of Physicians and Surgeons. And we hope that this will be of value to you for attaining your credits. And we all know that they're due at the end of next month. So let's get started with the program itself, and in terms of the learning objectives. And as I alluded to, they're quite broad. So really, the overarching aim is to address problematic areas that come up frequently in clinical practice, but are not necessarily dealt with by practice guidelines or are not sort of the typical cases. So we're looking at situations which are, challenging, and there may or may not be a right approach. And I think having a multidisciplinary panel like we have this evening will allow us for you, the audience, to get different perspectives. And once again, feel free to engage us, as we hope to make this as if we're really around a very large table in a very large conference room, socially distanced, of course. So these are the specific objectives. And let's get started then with a few more of the individual clinical scenarios. So this first case involves a patient who, this is the case that was provided to us by an audience member, but it really involves probably a panoply of scenarios. And I think the first part that I think is very relevant is that we're dealing with a patient who has lung cancer primarily, and with a cerebral metastasis, who has received chemotherapy and now has developed deep vein thrombosis. So I think there are two parts to this question. The first is sort of the general approach to patients who have, let's say, a solid tumor and develop cancer-associated thrombosis. And then the corollary would be patients who have a cerebral metastasis. So Jay, I'm going to ask you, what's your sort of overall management in general terms and in regard to patients who have cerebral metastases?
Yeah, this is an interesting case. I think that all oncologists appreciate that if someone has an acute blood clot, that there's an imperative to get treatment going right away. In this case, we see that the patient was treated with warfarin. That would not be the first choice, I would say. I think that most of us would lean towards a low molecular weight heparin, and now more recently a DOAC. So I think the answer to your first question would be, I think everybody would feel the need to treat. The cerebral metastasis makes this interesting because of the concern about bleeding, intracerebral bleed with any kind of anticoagulant. And I think that raises a whole set of issues there. This case could be taken so many different ways. Is it a single met? Is it multiple mets? Is that met resectable? Does it need to be radiated? Lots of different ways to go with that. Even if one wanted to get into the weeds with lung cancer, there are different kinds of treatments that we have. And the idea of drug interactions with various anticoagulants becomes a concern. Even some drugs like cisplatin, for example, it can be nephrotoxic, so it can cause damage to the kidneys. How do you manage that? It's also the most emetogenic drug we can give to a human being. And so if they're nausea and vomiting is not well controlled, can we give them a DOAC? So this case is absolutely chock-a-block full with lots of interesting cases, lots of interesting sort of branches. But to your two questions, one, I think everyone would want to treat in the acute setting, and two, cerebral metastasis, the concern about bleeding. I think that most of us, certainly speaking about me, I don't treat lung cancer per se, but would still want to treat blood clot, even despite the presence of a cerebral metastasis. But also, we'd be looking very actively to try and control that metastasis, whether that was with radiation or potentially surgical resection.
And Jay, thank you for that. So I'm hearing that the metastasis itself does not preclude the safe administration of anticoagulant therapy. Vicky, what do you think about that situation? If you're confronted with a patient who's got a solid tumor and they've got one or more brain mets, they were picked up on screening or because of symptoms. Does that pose a concern to you in terms of safety of anticoagulation?
Yeah, no, I agree with Jay. First and foremost, a cancer patient with an acute blood clot requires therapy and consideration for therapy, irrespective of the status vis-a-vis cerebral metastases. It is concerning per se with the advent, this has come to the forefront with the advent of the direct oral anticoagulants and their safety vis-a-vis certain special populations in cancer. And one of these special populations ends up being cancer patients with cerebral metastasis, only because the trials that we have to date, the edoxaban trial, the rivaroxaban trial, and most recently the Caravaggio trial, do not have a great number of patients with cerebral metastases in these trials. And so there is a lot of discussion vis-a-vis whether we feel low molecular weight heparin should probably be first line over a direct oral anticoagulant in these patients. I do agree with Jay that warfarin is not an option. It is potentially an option, but it is a second tier type of option should there be issues with using a low molecular weight heparin or direct oral anticoagulant. I pretty much, there is a fair amount of observational data and some of the subgroup analyses that are being meta-analyzed from these 3 cancer trials now using DOACs versus low molecular weight heparin in cancer patients that seem to show that there isn't a signal for bleeding. And so I am increasingly comfortable using a direct oral anticoagulant in these patients. I do look at things like whether or not they're high-risk bleeding mets, however. So for example, patients with melanoma, patients with renal cell, patients with thyroid cancer, these types of metastases may bleed more. And so I may be more comfortable starting with a low molecular weight heparin in those individuals. And finally, I do agree with Jay that irradiation, if there has been irradiated mets, I also feel a lot more comfortable given that there seems to, we're doing a control of that metastases with some sort of therapy.
Okay, well, thank you. So the bottom line is that you're good to go with either a low molecular heparin or a DOAC in patients who have acute thrombosis in the setting of a solid tumor with metastases, and it's always an important thing to come back to. Let's move on now. So we're switching gears a little bit, and we're dealing with patients who have unprovoked thrombosis, but don't necessarily have cancer. And this question from an audience member was, should we be screening, in this case, female patients for ovarian cancer if they have unprovoked VTE? And maybe, Jay, I can go back to you and ask you if this is something that you get confronted with, as an oncologist, or I guess the other question would be, is there value in your mind to be screening these patients for occult cancers?
Jim, to be honest, we're more downstream. They've already typically been diagnosed by the time with a malignancy by the time they come to a medical oncologist. But our recommendation in this situation would be if a female, in this example, presents with an unprovoked VTE, I think it's appropriate to do age-appropriate investigations. So, there may be a merit to doing, a breast cancer workup, for example. There are no specific guidelines for ovarian cancer per se that I'm aware of, but if someone had a family history that was very concerning, I think those are the kinds of things that would lead you towards doing more in-depth testing, screening.
Yeah, and I think we're all familiar with the Canadian-led SOME, it's SOME trial. And Vicky, I think you were a co-investigator of that trial. Can you tell us a little bit about that?
Yeah, so for the SOME trial, we enrolled patients at several centers across Canada, patients with unprovoked pulmonary emboli or deep vein thrombosis, to receive either standard of care type of screening that was age and sex appropriate versus a CT abdo-pelvis a study. And we chose the CT abdo-pelvis because preliminary information and looking at prior studies seemed to show that this was the study that was most likely to pick up occult cancers. In the end, that study ended up showing that there were no excess cancers picked up by CT scan versus regular sort of age and sex appropriate cancer screening. And so, as a result of that, I agree with Jay that the standard of care and the standard should be that these patients receive what is considered to be age and sex appropriate screening. And Jay, you're right, there's no sort of specific recommendation or guideline vis-a-vis ovarian cancer screening. But however, obviously, one needs to take a thorough history and look into the family history. And for sure, if there are certain high signals there, then potentially that may be a reason to think about screening in this individual. I can tell the audience that there is a second SOME study being launched, that has launched, and we're going to be looking specifically at patients who are over 50 years of age. And so for the first SOME 1, we looked at all comers. Here we're going to be age specific, meaning only looking at those over 50 years of age, because some subgroup analyses from the SOME study and others seem to indicate that perhaps that group may benefit from screening. And we're going to be using a PET scan instead of a CT scan. But that is far from, we're just starting to enroll into that study, so we don't really have any data yet. But I think it is an important question, and one that currently, we would only advocate for, as Jay said, for age-appropriate screening in this woman.
Oh, thanks. That's a great summary. And Maria, if I might ask you as well, you work at a major cancer center at Sunnybrook. Do you think, is that sort of the practice that you're seeing as well among the clinicians there?
So I have heard of perhaps doing it in pancreatic or questioning whether it's necessary for pancreatic. I haven't actually heard anyone suggest it for ovarian cancer.
Okay, so I think the overall response here is that we're need to avoid using kind of screening for occult cancers in patients with unprovoked or idiopathic thrombosis, unless there are clinical features that suggest a specific area that may be involved. And, the SOM2 study will further refine that, but for the time being, I think the standard is to just do age and gender appropriate screening. Let's move on. We got lots of questions to go to. And so the other question that comes up frequently is how to integrate the use of direct oral anticoagulants or DOACs in patients with cancer and thrombosis. And perhaps, Maria, we can kind of start with you. And now we have a number of choices in our patients with cancer and thrombosis. Is there kind of a general approach that you've used in your practice or that you've seen used at your place in terms of, which patients may be most appropriate for DOACs versus patients who may be most appropriate for a low molecular heparin in the setting of active cancer and venous thrombosis?
Okay, thanks, Jim. Yes, this is something that I've definitely been working on in our institution, just because there's a lot of confusion and we want clarity on what can be used, especially in the first line, and what can be used later on in cancer patients with active cancer. Many of them are on other therapies for cancer, have other risk factors for bleeding, as we've already sort of touched upon. So one of the things, and of course, we do seem to have a favoritism of which DOAC to get into as well. We can probably discuss that later. Based on the data at our center, it looks like our favorite is apixaban. But before we go into that, I think up front, it's really important to assess whether the patient has any contraindications right away to a DOAC, which some of them are clear cut in terms of, do they have renal dysfunction that would prohibit use of a DOAC? So in the trials, they excluded less than 30 mils a minute, but and we, of course, don't dose reduce the treatment doses. So that's another factor. And we know that renal dysfunction is a risk factor for bleeding. So we, of course, don't want to risk that. So we do feel comfortable sometimes using less than 30 mils a minute, depending on the situation. Some other contraindications that would be right away would be drug interactions. So it is important to have a pharmacist review the concurrent therapies, because if the patient is on, especially some that are completely contraindicated, such as drugs like rifampin, carbamazepine, or phenytoin, which are commonly seen for treating other conditions, then there is a risk that the DOAC will be lowered and not as effective. So right away, we can exclude some patients based on the basis of drug interactions. I'm not sure if you want me to keep
Yeah, no, that's very helpful. So, it's always great to have choices. And, increasingly DOACs are kind of our first line choice for cancer-associated thrombosis. Jay, what's your kind of perspective in this area, and low molecular heparin in which situations, DOAC in which situation, or do you kind of combine both?
We were seeing a shift for sure to DOACs. This used, a few years ago, this used to be the domain exclusively, really, of low molecular weight heparins. And I think the low molecular weight heparin that was used was probably the one that was most commonly used in your center, and it varies across the country. Here in Alberta, we use a lot of tinzaparin. I think that what we're seeing without question is this shift towards DOACs. I think there was a lot of question and concern when edoxaban first came out because of the bleeding risk and trying to clarify which patients were at higher risk of bleeding. That became a little bit more clear with rivaroxaban, that patients with luminal GI cancers, for example, were at higher risk. Those with urothelial cancers looked like they were at risk for bleeding. And then now I agree with Maria. I think the DOAC that we see most commonly used here in Alberta is apixaban. Seems to be safe for many patients, and again, there has to be a good workup in terms of looking at renal function. Is there adequate gastric function to actually absorb these drugs? But no question, I think the DOAC use is starting to really ramp up.
Okay, we got a question from one of our audience members who asks, do you dose adjust for acute VTE if your patient, presumably with cancer, is less than 60 kilos, or their serum creatinine is greater than 133 millimoles per liter, or they're over 80? So these are the criteria that we dose adjust for patients with atrial fibrillation. Vicky, do we apply these criteria to the VTE situation, in this case, in cancer patients?
I think that's such an important question. And I think Maria kind of did mention it earlier, but we do not dose reduce for the treatment of acute pulmonary embolism or deep vein thrombosis. And that can be confusing to people because we do have dose reduction for apixaban, and those are the criteria there noted for apixaban for atrial fibrillation. As well, we do have them for rivaroxaban. What I will say is that, as an overall statement, is that we do not dose reduce for apixaban or rivaroxaban. But for edoxaban, there is two doses. There's the 60 milligram and the 30 milligram. And in the Hokusai cancer VTE study, patients who had creatinine clearances between 30 and 50 mils per minute were put on the 30 milligram dosing. So we do not necessarily think of it as dose reducing edoxaban, but more of using the product monograph treatment dose for patients with those creatinine clearances, should we choose to use edoxaban for the treatment of acute cancer-associated thrombosis.
Thanks, Vicky. There's another question I'm going to ask the panel, actually, and it's just your thought about this, finding of increased bleeding among patients with gastrointestinal or genitourinary cancers, and what your kind of take on that is, and how much it affects the choice of whether to use a DOAC and or low molecular heparin. And maybe I can start with you, Maria. What's kind of your approach if you've got a patient who has a GI or GU cancer and an acute VTE?
Yeah, so I think at our center, at least, if it's an unresected lesion in the GI tract, or if it's a GU cancer that's hasn't been resected, we would definitely go towards a low molecular weight heparin, at least in the initial phases of treatment, just because that is the safer choice to go with at the lowest risk of bleeding, according to the data that we have. We may consider, based on patient preference, and later on when we have an opportunity to dose reduce something in the more prevention stages, whether it's past 6 months, past a year, we may consider introducing, you know, a DOAC at that point, but that's of course not something that's mandated by any guidelines or anything, more of a clinical expertise situation, and incorporating patient adherence and patient preference as well. Yeah, I don't know if that answered that.
Yeah, no, it's very comprehensive. Jay, what are your thoughts about that? Anything you'd like to add?
Yeah, maybe just to build on what Maria said, the DOACs need to be able to be absorbed, and that means they need, depending on the drug, some need an intact stomach, some need intact small bowel, and if you had a patient with an intraluminal lesion that was resected, let's say gastric cancer that was resected, and you were giving them adjuvant chemotherapy after that, the drugs may not be effective because they may not be absorbed well. So I think that, and I treat GI cancers, so I think that for me personally, I steer clear of DOACs in general for my intraluminal GI cancer patients, like a stomach cancer, just because I just don't think it's worth the risk, and we have drugs that are equivalent in the low molecular weight heparin.
Okay, Vicky, you get the last word about anticoagulations in GI-GU cancer. What are your thoughts?
I think, you know, we sort of do the same thing as described by Jay and Maria for unresected luminal cancers. We will begin with low molecular weight heparin. I think and then we would consider changing to a DOAC down the road, even before, for, you know, the 6-month mark potentially. I think with the Caravaggio study just recent, you know, that was published over the summer, and looking at their subgroup, you know, analyses, and albeit these are subgroup analyses and fraught with the limitations that subgroup analyses are fraught with, you know, the GI signal is not as prominent when looking at bleeding in the use of having studied apixaban in that particular study. Now, on the other hand, and Jim, you and I think, have discussed this in prior symposiums like this one, you know, the Caravaggio investigators already had an idea of the signal, with the GI signal being something noted with the earlier studies with rivaroxaban and with edoxaban. And so potentially patients were not, with GI malignancies, were not channeled through to this study as would have normally been with the other two studies. So all this to say is that I'm waiting to see whether or not this GI signal is a DOAC specific type of signal, or it's a you know, a drug specific or a class specific type of effect. And so I don't think we really have the answer yet. I am cautious. I do begin with low molecular weight heparin, but I'm more and more sort of waiting for these post hoc observational studies that will address this question probably better in the future. So that's sort of a non-committal statement, but I do begin with low molecular weight heparin, at least for now.
Yeah, and I'm with you as well. I tend to be a bit more cautious until we have more data, and typically would start with low molecular weight heparin, and then, you know, depending on other factors, may later transition them to a DOAC. We got another question, I think is a very relevant one, from Ryan Kersner. Thank you, Ryan, who asks if we do have a patient who is receiving a low molecular weight heparin, in this case it's dalteparin for cancer-associated thrombosis, do we really follow this kind of clot trial protocol where we reduce the intensity of anticoagulation to 75% of the therapeutic dose after about 4 to 6 weeks? Are we doing that in practice? So we'll just go around the table really quickly. Maria, is that something that is done in your practice?
Well, certainly we're not dose capping. I think that dose reduction to after a month of therapy or so is not consistently followed. And a lot of times, depending on when you have a patient with cancer-associated thrombosis initiated on low molecular weight heparin to start, oftentimes they are transitioned to a DOAC at that point when they're seen in the cancer-associated thrombosis clinic. So we oftentimes don't really even get to that point in time.
Okay, what about you, Jay? Do you sort of reduce the dose after a few weeks?
No. We just started the full dose. That's been our practice.
Okay, Vicky, what about you?
Yeah, we just stay on the full dose. I tend to be the same as well. I just keep them on a full dose because we know we have high rates of recurrence in this population. So, and if they're tolerating the drug and not having any bleeding, I keep them on the same dose. So, not strictly following the protocol. And we hear from the chat that even Dr. Lee, the author of the clot trial, may not adhere to this approach. Okay, I think we're going to move on to the next. Jim, we do have a question in the chat box.
Oh, yes. Okay, I just saw that.
Yeah.
So the question, I'm just going to read it off here. If a patient breaks through, so presumably this means they get a recurrence while on a direct oral anticoagulant, what do you do? Do you switch them to standard dose low molecular heparin? Do you switch them to, I guess, a low molecular heparin with a dose increase? So I guess the question is, what happens if a patient develops a recurrent clot while on a DOAC? Let's just go around the table once more. Maria, how would you handle that situation? Somebody's on a apixaban or a doxaban or rivaroxaban at a full dose, and then they get another episode of thrombosis.
Yeah, thanks. That's a tough one. I don't think there's a right way to go, but I think certainly first I would want to evaluate why that patient might have had a recurrence. Like, just look at adherence and were they able to absorb it? Were they having issues with vomiting? Were they vomiting their dose? If they do have a resection, what is the location of that resection? Is there a potential that they are not absorbing it? Were they taking it regularly? A lot of times it is compliance related. Or is there a drug interaction that might be changing things? So that would be the first step. And then, of course, is this a new thrombosis, or is there a new risk factor that was introduced that might have led to that? I think that might direct us on whether we're switching classes altogether or whether we can actually just change to a different DOAC that might be more appropriate for that patient. So I think it does vary depending on the situation, but we look at switching.
I like that. It's a very patient-centric approach, and I agree with you 100%. Jay, anything you want to add to Maria's comments?
Yeah, I think the only thing, if I'm getting a low molecular weight heparin and there's a breakthrough, I'm very comfortable going up by, say, even 25% of the dose, and assuming compliance, assuming that there's nothing new, sort of just building on what Maria said. That would be the only thing extra that I would add.
And anything from your point of view, Vicky?
No, I think I agree with Maria and Jay. I think we just need to remember that we need to have, though, a strategy if they do break through, because even in these DOAC studies, whether it's the Caravaggio with apixaban or the Hokusai cancer VTE or for doxaban or Select D for rivaroxaban, we're looking at rates of recurrence in those trials of around 5 to 6% in the DOAC arm. And so similarly, also in the low molecular weight heparin arms. So we need to address compliance issues, absorption issues, drug-drug interactions, as noted by my colleagues on the panel, but then have a strategy as to how we're going to deal with this, because 5% is 5% in a trial, and it could be And that's where we have, pure control, hopefully, of all these other matters. And so I think I often will switch over to another molecule, another class, low molecular weight heparin, rather than stay within the direct oral anticoagulant. That's usually my approach if I find no other reason for the failure.
And just the final point to add is that I think we're in agreement that if we do switch them for whatever reason, we'll keep them on a therapeutic rather than a super therapeutic 25% higher than the therapeutic dose, which we kind of leave in reserve as a last ditch kind of situation.
Yeah.
Okay. We got another question, and now we're going to kind of go 180 degrees in terms of topics from Francois Dubois, who asked that they had a patient with a submassive unprovoked PE 2 weeks after their second dose of the Pfizer vaccine, and the patient now is doing well and has completed 6 months of anticoagulant therapy. What are our thoughts about this scenario? Okay, well, I'll give it a start since I think we're all familiar with vaccine-associated thrombosis, or VIT. Now, there have not been any signals related to the mRNA vaccines, whether the Pfizer or Moderna. So I think that this episode, in my view, would be considered purely, coincidental and not related to the vaccine, unless there were other factors. The patient was unwell, immobilized for whatever reason. And to me, I would consider this as an unprovoked thrombosis, where I treat them as any other unprovoked or idiopathic thrombosis. So perhaps 3 to 6 months of treatment and then restratification thereafter. Anybody else want to chime in on this specific question?
Yeah.
Vicky?
No, I agree. I think there's many thoughts here. I think the first thing is to think that VIT, as mentioned by Jim, has not yet been clearly associated with mRNA-based vaccines. So if that's where, the thinking is, even if, let's say, it was a VIT due to AstraZeneca vaccine, for example, in those types of scenarios, we do have some guidance that indicate treatment would be as we would a provoked event or a HIT, for example, or heparin-induced thrombocytopenia, so generally 3 to 6 month therapy. But in this situation, I think I agree with you, Jim. I would manage this case as an unprovoked venous thromboembolic event, and then go through my risk stratification that I would normally do for an unprovoked. I don't know if this is a man or a woman. If it's a man, there are no risk stratification rules vis-a-vis prediction rules for recurrence. So likely this man would be on the intent for long-term or indefinite anticoagulation, barring, an assessment also of risk of bleeding and other comorbidities that can impact on risk of bleeding. And if this was a woman, then again, thinking about using a prediction rule such as, the HER2 rule or the Geneva score rule to look at risk of recurrence, and then making a decision whether or not this individual would be treated as an indefinite or not.
Yeah, no, I would totally agree. And then just very quickly before we get to the next scenario, a comment from Greg Soon about would we want to do a thrombosis consult in a patient with breakthrough cancer-associated thrombosis? Yes, yes, and yes. These are complex cases, and we want to engage our specialty colleagues. So if this is the case, then please do so. All right. So finally, I'm going to go on to our next scenario. And it's just taking a while for my slide to advance. My apologies for that.
I just want to, while you do that, I think there was another question we use a lot of enoxaparin, and do you recommend full dose 1 milligram per kilo twice a day, or the reduced dose 1.5 milligrams per kilo once daily for cancer-related VTE? So that was put in the chat box. I don't know if, Maria, you have any experience with either dosing or preferentially use one dosing?
So in our guideline for CAT, we have either as options, so the 1.5 milligram per kilogram daily of enoxaparin, or the 1 milligram per kilogram BID. For somebody where the injection would become too much, above 100 milligrams, say in the total daily dose, we would generally do those on the 1 milligram per kilogram BID dosing, just to make it easier on the patient. I think most of us probably pick the daily option. We use enoxaparin at Sunnybrook, so many of us will tend to that, just to give the patient less injections.
Okay, thank you, Maria and Vicky. We're going to move on, and this question I got from before was just dealing with catheter-associated clots, and of course, we're seeing a lot more of these. And maybe I can come back to the situation where we have a patient who's getting chemo, Jay, and has got either a Hickman or a portacathin and develops a line-associated clot. The line is still working. How would you be handling those patients, or what's your experience with these patients? A DOAC, a low molecular heparin. I guess we're going to probably avoid a vitamin K antagonist.
Right. I think the key thing here is that the current philosophy is to try and protect the line as much as possible, try and keep the line. So it used to be that we would remove the nidus, if you will, and then try recite a new line. And that really isn't our philosophy anymore. Now we look to protect the line. And so all of us, I think, are comfortable. I'll probably have more experience, though, with low molecular weight heparins and just using them in conjunction with a line and trying to get that line to continue to work as long as we can.
Yeah, I totally agree. Keep the line in, especially if it's not infected and functioning. I'm also reticent about using DOACs as first line treatment in these situations. We have more experience with heparins, and there's some early data, observational data from Western Ontario that DOACs may not be optimal in terms of safety. Okay, I'm going to go on and talk about, or ask someone to share with us their view about the Trop Study. This was brought up by one of the panelists. Vicky, do you have some familiarity with this study? And I think it ties into our previous discussions about cancer-associated thrombosis.
Yeah, so the Trop Study is a study, it was an observational study done out of the US and presented at ISTH over the summer. It was a prospective study looking at cancer patients with acute venous thromboembolism and thrombocytopenia, and looking to see what the rates of recurrence and major bleeding were in patients who received, reduced dose anticoagulation. And so perhaps stepping back, the ISTH SSC Gyne Cancer Committee subcommittee looking at a few years ago published their recommendations as to how to manage a cancer patient with thrombocytopenia who also has an acute blood clot, given that this is a situation we commonly come across with the thrombocytopenia being the result of bone marrow invasion of the cancer or myelosuppression by cancer therapeutics. And so, and having a lowish platelet count does not negate the patient getting a thrombotic event. And so interestingly, the guidelines come up with, depending on whether the clot is acute or chronic, and depending on the level of platelet count, patients can find themselves being on half-dose low molecular weight heparin if their platelet count, if it's an acute DVT or PE, and the platelet count is between 50 and, around 50 to 75, and then they would be put on a reduced dose, given the fact that we want to be able to provide some sort of anticoagulation for this event. Anyway, this study showed that there was no excess risk of recurrence in those that were in the dose-reduced arm or had dose-reduced anticoagulation regarding when dealing with platelet counts that were below 100. And so it gives us some, granted this was a small study, I think it was something like 150 or 180 patients, but it gives us some sort of confidence that we could manage patients in this manner, meaning reducing our dose according to the platelet count in cancer. Now, this is only for cancer patients. This is not something that has been looked at as scrupulously in non-cancer patients. But this is the issue comes to hand when dealing with our cancer patients in thrombocytopenia.
And Jay, I mean, when patients get chemo, their counts may drop. I mean, typically maybe not to very, very low levels, but is there, what's your kind of comfort level from an oncologist standpoint about platelet counts and therapeutic anticoagulation? Is there a cutoff that your comfort zone kind of exceeds?
I mean, I think thrombocytopenia is so common for us because of chemo. So we're comfortable with lower counts, and really navigating those waters are pretty common for us. I personally feel comfortable with aggressive anticoagulation, even with platelet counts up to 50. I'm comfortable with that. I think most of us in our center here will be quite aggressive with thrombocytopenia, a new clot thrombocytopenia, platelet count to 50. And I think that conforms with a lot of what many guidelines also recommend. So that's sort of certainly my own approach.
Yeah, and I think as Vicky was alluding to, it also depends on what stage of the thrombosis you're in. If you're in the acute stage, you probably want to try to get them at a therapeutic dose as much as you can, whereas if you're like a month or 6 weeks out, then you could probably be more comfortable to drop down the dose.
Right.
And and the findings from the Trop study provide some reassurance about that. Okay, we have another, actually there were a couple of questions from Dr. Upneya, and forgive me if I'm mispronouncing your name, who asked about general risk stratification after about 6 months of anticoagulation. And actually there's a second question relating to use of anticoagulants in patients with severe end-stage renal disease. So the first question about factors, just general factors to risk stratify after 6 months. Vicky, what do you think about that? And then the next one, I'm going to go to you, Maria, about anticoagulation in patients with creatinine clearance less than 50 or on dialysis. So Vicky, risk stratification.
Yeah, so well, I guess for cancer patients, if we had to just look at cancer patients, we don't really have a whole lot of data as to what to do after 6 months. And so most of us will tend to continue full dose anticoagulation, whether it's low molecular weight heparin or a DOAC, or we may even switch one for the other. If the cancer remains active, and or the patient is still receiving acute treatment for that cancer. So generally speaking, that's although there are prediction rules that have been developed in this patient population to determine if certain cancer patients can be stopped. These have not been prospectively yet validated. So for now, we tend to I will continue if the patient still has an ongoing active cancer, followed by their oncologist and or are receiving active therapy. And it's a conversation I have with the patient and the oncologist to consider, whether or not the patient is in remission or not. These are the factors that come into play. And so I think it's specific for in non-cancer patient, there's a whole slew of data as to how to approach that. And generally speaking, overall, it depends on whether the clot, I assume we're dealing with unprovoked clots, because provoked clots by major transient risk factors will stop at 3 months, generally speaking. So major trauma, major surgery, an extended hospitalization with immobilization and that sort of thing will stop at 3 months. But in patients where there's no identifiable, risk factor, or there's like a mild transient kind of risk factor, then in those individuals, we do have risk stratification rules that we can use to determine who goes beyond that 3 to 6 month period of anticoagulation. And I alluded to those earlier. These are patient characteristics that are put into prediction rules. One of them, one's born out of, Ottawa, Ontario, was the HER2 rule. And specifically that looks at specific characteristics in women and identifying which women have a low risk of recurrence if they stopped anticoagulation at 3 to 6 months. By low, meaning around 3% risk of recurrence, and which women, if they fulfill positive enough points on the score, have a higher risk of recurrence, around 7 to 8% annually of having another DVT or PE, which is similar to a man having also, if they had an unprovoked. So I think different ways of risk stratifying depending on the patient's scenario. So there is a lot of sort of that comes into thought at around that 3 to 6 month mark after an acute treatment. That's why all these patients need to be brought back at that period of time to address risk of recurrence versus risk of bleeding should they, remain on the anticoagulant. So a lot of factors come into play.
Yeah, definitely a very patient-centric and complex, potentially complex issue. So we've been dealing with a lot of what-if scenarios, and an important one, Maria, is what if your patient has a very advanced renal insufficiency with or without cancer? So we're talking about, creatinine clearance less than 15, or they're on dialysis, and they develop acute thrombosis. And do you have a sort of a general kind of approach to these individuals? Very challenging and not the most robust data. So we'll acknowledge that.
Right. So I think the first thing would be to consider what the indication is. If we're talking thrombosis, or is it atrial fibrillation, because that will impact. So if we're talking thrombosis, of course, we don't really have guidance or recommendations for dose reductions of the DOACs as a treatment. And of course, enoxaparins and low molecular weight heparins are renally cleared to varying extents. So in the case of low molecular weight heparins, the one that we're most comfortable using in more advanced renal disease would be tinzaparin, just because it's the least renally cleared. And then in terms of the DOACs, the least renally cleared is apixaban. Then if we get into hemodialysis, that brings into a different picture. So we would definitely be engaging the colleagues, their nephrologist, the nephrology pharmacist, in terms of making a decision on the best anticoagulation, because of course we know that warfarin is safe in renal dysfunction, and that's the preferred choice for renal dysfunction.
Yeah, and I would agree with you completely, Maria, that we just don't have enough safety data with long-term low molecular heparins. we could probably get away with using them for a short period of time. By that I mean, 4 to 5 days, even among dialysis patients. But with DOACs, I don't think we have sufficient data. And although it's not the most ideal option, I think the default treatment here would be a vitamin K antagonist. Do you have any other experience from your center, Vicky, on dialysis patients with acute, venous thrombosis in whom there's another indication for full anticoagulant therapy?
No, we do. It's similar to what Maria explained and yourself. In these patients, unfortunately, it's an important question and one that is being addressed, albeit it is a challenge to address. There are AFib studies, for example, looking at dialysis patients, randomizing them to a DOAC versus Coumadin versus nothing, actually. And there is significant equipoise there, where there are studies now that do show that probably there could be more harm using warfarin, for example, in these patients and associated complications. But we will occasionally, like you described, Jim, use low molecular weight heparin if it's for a short period of time. And by that, I mean days, not ongoing into weeks, for example. But unfortunately, at this point in time, vitamin K antagonists are the way that we deal with these patients.
And I can only add very quickly that I know a lot of nephrologists are, reticent to use anticoagulants, especially warfarin, in end-stage renal disease patients because of the concern about calciphylaxis. I think that's more of an issue in a situation like atrial fibrillation, but for acute venous thromboembolism, we have to, that's sort of your go-to drug still, perhaps with a short initial period of low molecular heparin. Okay, we're going to move on to another scenario, and if I can advance the slide here. But we're dealing with a lot of kind of important issues that pertain not only to the cancer patients, but to non-cancer patients. So here's a very comprehensive scenario that was brought forth by one of the audience members. And essentially, if I can summarize it, it involves a 20-year-old patient who is on a progestin-only contraceptive, who comes in with calf pain, and then subsequently was empirically started on a direct oral anticoagulant. So I think there are a number of issues here. And the first one may be, do we consider a progestin-only hormonal therapy agent as a risk factor for thrombosis? And if so, would we, in this patient, if let's say that they had a calf DVT, would we then not allow them to use this agent for, whatever, typically for contraceptive reasons rather than dysfunctional uterine bleeding? So this is a challenging situation. And maybe, Vicky, I can start with you. What are your thoughts about progestin-only agents and thrombosis? Are they associated with an increased risk for clotting?
So, I think the audience member, has hit it on the nail. There are different oral contraceptive pills, and the thrombogenic aspect to the oral contraceptive pills falls with the estrogen component of the combined oral contraceptive pills that include a progesterone and an estrogen. And moreover, we do know that the dose of estrogen is linked directly to the risk of thrombosis. So the higher dosed formulations have a higher risk of thrombosis when they have a higher concentration of estrogen. So the combined oral contraceptives, there's good data to suggest that there is, and there is irrefutable data to suggest that there's a risk of thrombosis. But with the progestin only, there doesn't seem to be, at least in the several observational data studies that have been done to date, including large-scale administrative database studies, that there is a higher risk of thrombosis with progestin only pills. And in fact, in one study, there seemed to be a protective effect. So it's not clear whether or not in that study, it may have been that a progesterone-only pill is not as highly contraceptive, I guess is what the term. So maybe these women had pregnancies, and that's why there seemed to be showing a protective effect with the progesterone only. But in general, I do not consider them to be as at a high risk for thrombosis, and in fact, will recommend them to women once they've had, a prior DVT or PE and require some sort of contraception in the future. I would probably recommend that. But so in this case is a challenge. It seems like the individual had calf pain following usage of the progesterone-only pill. It's not clear to me whether or not this calf pain ended up being diagnostically shown to be a clot, but I wouldn't have thought that this would have been an important factor here.
Yeah, and just very quickly, I would agree. I've treated a lot of patients with prior thrombosis who required contraceptives, and usually I recommend the progestin intrauterine device because it may have less systemic absorption than the pill, which isn't used too commonly, or the subdermal implant. And as regard to actual risk, the only caveat is that we don't have nearly as much data with progestin-only formulations as we do with combined estrogen progestin formulations. Right. And there may be a dose effect. And Jay, I'm just curious, because I've read in the literature that sometimes oncologists have used like high dose medroxyprogesterone in patients with cancer with anorexia or other constitutional symptoms. Is that still done nowadays? It
used to be done, actually, when I was 10, 15 years ago. I think it's not used commonly at all now, but for sure it was. I haven't heard of its use in over 5 years. Yeah.
And sparingly, I see the use of Depo-Provera, the every 3-month injection. Just staying on the hormonal therapy line. In fact, we had a scenario about this, but Michelle Lamarche asked whether we attribute an increased risk of VTE in people who are receiving testosterone therapy. I'm not sure if anybody wants to tackle that one. Vicky or Maria, maybe I can lean on you because I'm not sure there's a clear answer here.
Yeah. Well, I mean, actually, we were involved in we performed using UK data, large administrative healthcare databases. We actually looked at this question of testosterone use, testosterone hormone therapy in men. And in our database, I can't recall, this was about 4 or 5 years ago, we published this. It was really a large sample size. We did not see a signal with testosterone for thrombosis. Now, I'm talking about venous thromboembolism. There are also suggested links with arterial events. And so that, needs to be we need to be mindful about that, and whether or not there's a link there. There are studies that say for and against that, but I can say that I think for venous thromboembolism, I don't believe that there is an important link there with testosterone use.
And Maria, do you have any kind of experience or thoughts about androgens and thrombosis risk or in your practice?
Right. So I agree with what Vicky has mentioned so far in terms of the large-scale meta-analysis and that have been done, and observational analyses that have been done so far don't seem to suggest a clear answer or a clear risk involved. But I know that it is something, because theoretically, right, testosterone can increase the hematocrit, which can increase thrombosis. So certainly it's something that we might look at or evaluate and assess their dose and that kind of thing. But I agree with what Vicky has mentioned about not being certain that that is a true risk factor.
Okay, thank you. Certainly an area that warrants further research, and glad to hear about the work that you and your team is doing, Vicky. So the next scenario involves a thrombosis that is termed an unusual site, in this case, extensive portal vein thrombosis extending into the mesenteric system in an otherwise presumably well 38-year-old male who has no other provoking factors for this thrombosis, but has a thrombophilia workup and is found to be a heterozygous carrier for the prothrombin gene mutation. This person is anticoagulated indefinitely, and is there any further guidance? Well, maybe I can start having a crack at this. This is a situation where we really want to look for any kind of provoking factor, because on thrombi in the splanchnic veins without any, whether it's an acute inflammatory process or an infectious process or obviously a malignant process, is really unusual. And I don't think I would attribute this to just being a heterozygous carrier for the prothrombin mutation, because we know that is generally a weak risk factor. So I guess my thinking is that I'd rather not have to anticoagulate somebody indefinitely, especially if they're 38 years old, and maybe treat them for a 6-month period or a bit longer until the clot is resolved. There are clearly not a lot of data in this area, and we're seeing a lot of these clots, but many of them are incidentally identified. And Jay, you see a lot of these in the cancer population when patients undergo screening. So, Vicky, would you maybe agree with me or disagree with me? And either's fine.
Yeah, no, I agree totally with you. I think this is an atypical clot, and it's quite extensive in a young person, and I wouldn't simply attribute it to a heterozygous prothrombin gene mutation, although it is an important consideration. But I think when we look at the epidemiology of portal vein thrombosis and mesenteric thrombosis, we tend to think about looking for risk factors, and things to consider here would be the myeloproliferative disorders. So things like polycythemia vera, for example, essential thrombocytosis or themia, or, these types of disorders can present with splanchnic vein thrombi and not yet have the phenotype of these malignancies. So it is important to look at that CBC, to do a thorough exam, to look for, splenomegaly and whatnot, and I would actually, having this patient do a prothrombin gene mutation, I would actually look at, a JAK2, for example, CALR, just to rule out a myeloproliferative disorder. And that's what I would be thinking, really, in this situation.
Yeah, and just to add, if the circumstances are appropriate, also it's one of those things we want to remember in the back of our heads as PNH or paroxysmal nocturnal hemoglobinuria. Jay, what if this patient was just asymptomatic? A lot of your patients get follow-up CT scans, and I'm sure you see a lot of these clots. Yeah. What do you do? Do you treat all of them with low molecular heparin or a DOAC, or how do you handle it?
I think most of us will treat. Very commonly, we'll see splanchnic vein clots in metastatic patients who are getting treatment for life, and so they'll get lifelong anticoagulation in many cases. I think where it becomes a little bit controversial is more like in the lungs, or if it's in the very periphery, do you consider those to be real or not? In the splenic circulation, I think most of us would anticoagulate.
Okay, and Maria, do you have any additional thoughts just about the cancer, the non kind of cancer patients, just in terms of treatment, and if there's a go-to agent or class of drugs? I certainly don't think there's more emerging evidence on DOACs, but how do you handle these kind of patients in terms of the choice of anticoagulant?
Right. So, when I read this case, definitely what came to mind was the myeloproliferative neoplasm in the JAK2. But certainly in a cancer patient, that would definitely, as Jay mentioned, lead to anticoagulation as the decision, and perhaps even, long-term likely to prevent such a extensive clot or recurrent clot. In terms of the agent used, I don't think there's a right or wrong answer. The same principles need to apply in terms of what's the most safest option for that specific patient in terms of their other factors and other characteristics. We have some, I know I had to submit for approval of a DOAC recently, where because there's very limited data for using DOACs in this kind of clot, really just like a retrospective kind of data, but it does, like as you mentioned, it is starting to build.
Yeah, and I think we're seeing more data, especially in patients who don't have cirrhosis, like advanced cirrhosis, because that's where we want to use DOACs with caution, and typically we would probably go to a low microheparin, but we're seeing more data on splenic vein thrombosis and the use of DOACs. I think we've kind of covered this scenario when we talked about testosterone, and this is a patient who requires ongoing testosterone therapy. And I guess the question, maybe we just quickly go around, or maybe Vicky, if you could give us your thoughts on how to handle this situation.
Well, I mean, I think, we don't have a lot of data vis-a-vis testosterone and risk, as we mentioned earlier, but I think one of the things that comes to mind here is I wouldn't necessarily think in a 50-year-old man that it would be the testosterone itself that would be the risk factor. If it is, then I would attribute it as a minor risk factor, sort of the way I deal with older women on hormone replacement therapy. I consider that to be a minor sort of risk factor. And so I would tend to look at treating these patients more than 3 to 6 months, especially in this man where we know the risk of recurrence in an unprovoked type of situation is high, or looking for, like we talked earlier about, are there any other signals here for an occult cancer, like the basic, history, physical exam, CBC. And, I don't know why he started testosterone therapy. Could there be something there that has an underlying, reason as to why that individual started testosterone? So there's a lot of investigation, but if in the end, there's nothing screaming, another secondary cause, then I would probably deal with it as I do with, the low risk that is associated. OCPs have a higher risk of thrombosis than according to the dosage. And so I would probably think that this is a low risk kind of formulation and would benefit from probably thinking long-term anticoagulation.
Yeah, and I would agree. I think the most important thing that I heard is that, we're dealing with somebody that may have been on this treatment for a while, and you don't want to attribute it just to the use of this agent, as we would not to a young woman being on the pill for many years, or a perimenopausal woman being on hormonal therapy for a number of years, although we don't see that too often. Okay, I'm just going to switch gears a little bit. We've almost coming to the end of our session, and please, feel free to, if you have any questions that you want, burning questions for the last 10 minutes or so. So this is a very common situation dealing with periprocedural management. And, there's what this case, I think, illustrates involving a patient who's on warfarin and needs an endoscopy procedure is whether they should be they should be continuing anticoagulation or versus stopping it and then maybe bridging patients, and how do we reconcile that management with guidelines? For example, at Thrombosis Canada, I'll just sort of quickly address this. I think, the reality is that a lot of the guidelines, including Thrombosis Canada and the GI specialty guidelines, suggest that you can do endoscopies without stopping anticoagulants. However, a lot of clinicians, surgeons, gastroenterologists want to stop the anticoagulant. And the justification is that, well, what if if I find a polyp that I have to snip, and that could cause a lot of bleeding? For most procedures, you can safely continue patients on an anticoagulant, even if they're having, biopsies, and this is supported by GI practice guidelines. But if you do need to interrupt them because that's what the proceduralist wants, I would suggest just avoiding the use of bridging anticoagulation altogether in that situation. And to just interrupt the warfarin and then just resume it. The one thing, if they are having a polyp, is that we know that the bleeding can be delayed. So yet another reason not to bridge these patients, because we don't want an intense anticoagulant effect at the time when that polyp resection is healing. Okay, we've got another question here. I promised that I would take them the last 10 minutes. The question is, when, if ever, are you using a post-anticoagulation D-dimer after stopping anticoagulation, presumably in patients with unprovoked thrombosis, or are we using it in some of the situations we just described with hormone-associated thrombosis? So, Maria, maybe I can ask you at Sunnybrook, are you using D-dimer as a risk stratification component after idiopathic or even after hormone-associated thrombosis to determine risk of recurrence and then need for anticoagulation?
Okay, I'll try my best. I'm not sure if I know the exact answer, but I know I asked this same question to my doctor and colleague that I work with in the clinic at the thrombosis clinic, and her answer was that we don't tend to rely on the D-dimer as much as the guidelines would suggest. But that being said, I'd like to bounce this off the other panel members for sure.
Vicky, what do you think? How are you using D-dimer, if at all?
Well, we use D-dimer as a standalone test. We do not use D-dimer although there has been a lot of in the past studies looking at standalone D-dimer plus or minus repeat Dopplers, for example, for residual blood clot. To determine whether or not we risk stratify those patients as, high, medium, low, whatnot, and then make a decision as to whether we continue anticoagulation. I do use it as part of this, the HER-2 rule, for example. So the HER-2 rule is a rule that was devised and validated a few years ago to be used in unprovoked cases in women to determine who is at a higher risk of recurrence. And in that group, you could potentially also put women with hormone-associated clot, because it is, it's a case by case, whether, if it's clearly a woman who just started the pill and 2 weeks later gets a big PE, I think we could all kind of say that, that individual PE was provoked by that clot. But if it's a woman who has been on an oral contraceptive for many years and then develops a PE, then I would consider using this risk stratification rule that includes looking at a person's age, whether or not they have evidence of post-thrombotic syndrome, and doing a D-dimer actually. And then as a result of the points that are garnered on that score, the patient then falls into a higher risk of recurrence. And then that can guide me as to whether or not I stopped in my anticoagulation.
Well, I thank you, Vicky, and that makes I agree with you. The only caveat from my perspective is I tend to be a bit more agnostic in regard to the clinical decision rules, and I tend to use D-dimer a lot more, even in males. Especially if they have a low burden of thrombosis, and I really want to get them off the anticoagulation. So I think there is a role, as Vicky said, it's really a very individualized management. The clinical prediction guides, whether it's HER2 or the Vienna score or the DASH score, are there to help you, but they're not there to make the decision for you. There's a lot of factors, not least of which are patient values and preferences that come in. Okay, we're kind of in the final stretch here, and we had a question about HIT, but I thought we could deal with something a little bit more germane, and that is kind of switching patients who are in hospital from a low molecular heparin to a DOAC, and that transition to care issue. Is there a kind of easy way to do that? Maria, you're dealing with a lot of hospitalized patients. Let's say they come in, they start on a low molecular heparin. Is there an easy way you can transition to a DOAC if, let's say, they're going home, or even if they decide to stay in the hospital? Will you keep them on the low molecular heparin and not changing to a DOAC if they're still in the hospital?
Yeah, I think this is a great question. So the general approach would be that if they don't have any contraindications or considerations where a DOAC would not be reasonable, you would definitely want to set that patient up so that they're comprehending what kind of therapy they're going to be going home on and making sure that they're tolerating it prior to leaving the hospital. That's what would make more sense to me. But of course, you do want to make sure this is a hospitalized patient. So, is their gut functioning? These types of things. Are they on other therapies? Are they at a high risk of bleeding right now? And then the other thing to recognize is how soon you can switch does depend on the DOAC you're switching to. So something like rivaroxaban or apixaban doesn't really require you to use low molecular weight heparin first, but if you were going to treat with, I know dabigatran can be used, but rarely, but specifically doxaban requires at least 5 days of low molecular weight heparin up front as well.
Yeah, and I would agree with that. We've with the DOACs, if a patient is on a low molecular heparin, I mean, you can keep them on longer if you want. Let's say if they've got a really extensive iliofemoral clot and you want to maximize the anti-inflammatory effect that you get with a heparin, but you don't get with a DOAC. There is flexibility, but it's pretty easy to transition them. Just, their last dose of the low molecular heparin is one day, and then they switch seamlessly to a DOAC the next day. And well, we can go back to that, if I can bring it up, that question about heparin-induced thrombocytopenia. I think it's topical because we were dealing with vaccine-associated thrombosis and thrombocytopenia, and the question was about the use of DOACs. So, Vicky, maybe I can ask you, what's your kind of go-to anticoagulant in a patient with HIT, or, not that we'll see it in Canada again, hopefully, but in the VIT population as well?
Well, I guess, Yeah. So obviously with heparin-induced thrombocytopenia, in hospitalized patients, as a result, we tend to not use obviously any heparin products, and we in a confirmed case, we will treat these patients with, for example, the pentasaccharide fondaparinux, or if there are issues of, renal failure or whatnot, then we will go on to other anti-10A, for example, argatroban, for example, we can use as well. But these patients will then be quickly transitioned over to an oral agent. And more, the oral agents that we end up using are with increasing data suggesting that once your platelet counts have recovered, that you can potentially also use not just vitamin K antagonists, but you could potentially also use a direct oral anticoagulant, although this data is not as robust as it is for vitamin K antagonists. But certainly we would not be, using any heparin products in these patients.
Yeah, I agree. And I think the DOAC is becoming the go-to agent in my practice. There's a comment from the audience about dinaparoid, which we used many years ago, and then it was not available. It's kind of back, but we're not really using it very often. Again, this is another scenario where consultation with a hematologist or thrombosis specialist, any kind of hit scenario is warranted. All right. Well, unfortunately, we didn't get to all of the scenarios that we wanted to cover, but we did cover a lot of ground today, and I hope this was helpful to the audience to have this kind of informal approach and a multidisciplinary perspective. I'd like to end the session by acknowledging the support that we received from Pfizer Canada to provide an unrestricted educational grant for this. I'd like to acknowledge also that a lot of what we covered today this is shown on the Thrombosis Canada website. For example, we have a new tool on thrombophilia, and of course, a lot of resources on cancer-associated thrombosis. And then, of course, I'd like to thank the panel tonight, Dr. Easaw, medical oncologist from Edmonton, Dr. Vicky Tagalakis, internist and thrombosis specialist from McGill and Montreal, and Dr. Maria Marchese, a clinical pharmacist from Sunnybrook Hospital in Toronto. And of course, thank you very much. Thank you again, everyone. And I hope you have a pleasant early evening in the West Coast and late evening in the rest of Canada.
Goodbye. Good night.
Thank you.
Good night.
Bye.